Thank you for this kind invitation. I'm a hematologist and transplant physician. My specific interest in infection. So transplant is my everyday practice, it's my everyday work. I cooperate with microbiologist and with infection disease doctor. However, I am hematologist. So I was thinking how to prepare the presentation for you, and I decided to tell you about infection and why it is relevant for transplant outcome. It is not easy to describe this very huge area, very huge subject in 40 minutes. However, I will try to point the most important factors related to infection. Generally, why infection are important after transplant? It is a universal problem. It is universal because we treat hematological malignancies or other diseases, not only malignancies, which are connected with impaired immune system. Our treatment, stem cell transplantation, this is immune-directed treatment generally. And additionally, there are some common pathomechanism of different diseases and infection, also malignancies and infection. There are some characteristic points related to infection after transplant, because we have, first of all, opportunistic infections. It means that pathogens are rather safe for healthy person, but they are pathogenic for patients with impaired immune system. We observe also atypical symptom of infection. They can disseminate in very short time with completely atypical clinical presentation, and that's why infection is recognized, is diagnosed with deletion, and it may produce increased mortality. If we look at rates of mortality, is stable through years. Those data are from CIBMTR, and so they show that after allotransplants, we can see early mortality in about 20%. If we look at previous years, it is almost the same, 17, 18, 20, and again. But of course, in patients undergoing autologous transplant, this rate of mortality related to infection is a little bit lower. Of course, infections are relevant looking at mortality reasons in analysis of different groups from different points of the world. In Spain, for instance, invasive fungal infection as one of the most important factors related to mortality after stem cell transplantation. Sweden, CMV infection. Australia, invasive fungal infection and CMV infection, but also in Taiwan, all different kind of infection are relevant for mortality. Here you have Polish data concerning pediatric center, and you can see that in allotransplant, it was published a year ago, you can see that in patients, children undergoing allogenic transplants, we observe first of all viral infection, and those after autologous transplant bacterial infection. This year, today we have also poster comparing autologous and allogenic transplant results according to infection between children and adults, and those data are based on more than 3,000 patients. So I think that those data are quite interesting. We are trying to publish it also. So why we have such problem? It is because immune reconstitution is impaired after stem cell transplantation, and this immune reconstitution reflects the risk of infection. This risk of infection, of course, is also dependent on status on hematological disease at transplantation, comorbidities, the age of the patients, neutropenia, disruption of anatomic barriers. I will tell about you depressed T and B function, but also type of transplant, also source of stem cell, conditioning regimen, degree of histocompatibility, graft versus host disease prophylaxis, and occurrence and type of this complication. This is a well-known slide and a well-known classification of phases in which we observe different form of infection. Of course, border between those phases are not very strict, but we have to analyze it in some points. So that's why one of the most important is first phase. This is pre-engraftment phase. We think it is up to 30 days, up to plus 30 days. And during this time, we have, first of all, neutropenia, some abnormalities concerning barriers, anatomical barriers, T cell and B cell function. The second, this is after after 30 days up to 100 days, with some abnormalities related to immune function, and late phase observed first of all in patients undergoing allogeneic transplant, and this is related mainly to complication related to graft versus host disease. So we have different form of infection, bacterial, fungal, viral, protozoal. I will focus on bacterial, fungal, and viral. And we have, of course, different strategies. We have definition, we have risk group stratification, we have diagnosis and monitoring strategies for different form of infection, prophylaxis and treatment strategies. And those strategies are usually empirical, preemptive, and targeted. And those strategies are prepared by different international societies and groups, scientific groups. I would like to start from bacterial infection and start from pre-engraftment phase, which is common for all types of stem cell transplantation, both autologous and allogenic. So infection during pre-engraftment phase can occur with the same almost risk, just like and rate, just in all types of transplants. The main risk factors during this time, this is neutropenia length and neutropenia degree. Severity of neutropenia below 0.5 and length of this neutropenia is very important. Additional factors are mucous membrane damage, central venous catheters emplacement, and of course immunological impairment. Generally, we do classify those infections into three groups: as febrile of unknown origin, as clinically documented infection. This is infection in a patient with pneumonia, for instance, without known bacteria, but documented pneumonia by CT scan, for instance, or by X-ray picture, or microbiologically documented infection. Such infection during neutropenia are described in 30 to almost 90% of patients undergoing transplant. Those changes are related to type of transplant, because in patients undergoing transplant because of multiple myeloma, the rate of infection during neutropenia is really very low. But in patients who are treated because of acute myeloid leukemia from unrelated donor, and the treatment is given to the patient without complete remission, the risk of infection during neutropenia is higher. The most common is bloodstream infection, and this is the most dangerous, and I will show you this on next slides. And it is described that it is present in 20 to 60% of patients. It is also very important what is the etiology of this bloodstream infection or other infection, bacterial infection detected in the patient, because prognosis of patients who are infected with gram-negative bacteria is worse than those who are with infection caused by gram-positive infection. So etiology is very important to predict prognosis. So, of course, we have different forms of treatment and prophylaxis, environmental and pharmacological. This environmental is very important because we do provide transplantation at home, not only in hospital. That's why this description is important. And pharmacological, which is given to most of patients, however, not in all centers in Europe. Empirical antibiotic therapy with two models, the escalation and escalation, and of course, targeted antibiotic therapy with some important points, just like antibiotic choice, treatment duration, and antibiotic dose. Here you have data showing how important is bloodstream infection on generally on survival. In those patients after allogenic transplant in whom bloodstream infection was detected, survival rate is lower. And the same concerns etiology. If bloodstream infection was caused by gram-negative bacteria, it has a very significant impact on survival. Additionally, those patients who undergoing allogenic transplants, especially from mismatched donor, they do worse during such a complication related to bacterial infection, especially caused by gram-negative bacteria. So the most important data during this pre-engraftment phase are related to neutropenia at time of infection onset, first of all, length and severity of neutropenia, etiology of bacterial infection, gram-positive versus gram-negative bacteria. Site of infection is very important. The most common and the most dangerous seems to be bloodstream infection, but also pneumonia, central nervous system infection, abdominal, urinary tract infection, skin infection. And of course, forms of prophylaxis, because it may have important impact on the resistant bacteria, for instance, in the future in the patient, given treatment, and of course, outcome of this infection. But of course, we observe infection not only during pre-engraftment phase, we observe it also after this time, during this intermediate period and late infection. And it was such analyses were published only by several authors. This one was published by and analyzed by Ljungman 10 years ago, and during last ASH meeting, it was also presentation related to late infection, and it is problem. Probably we do not analyze it in appropriate way, because in patients 6 months after transplant, we observe a number of different infections, especially caused by bacteria, encapsulated bacteria, and it may cause 6.4% of deaths, late deaths. 66% of such infection occur up to 18 months after transplant. And fatal infection, unfortunately, there is no plateau. This is the curve. There is no plateau of fatal infection after transplant. So they're coming up even 12 years after transplant. That's why I think that we have to prepare for this, maybe in this new form of our registry, to look at late infection also and influence on mortality. For now, we know that graft versus host disease, transplant from unrelated donors, especially from donors, mismatched donors, after TBI or with recurrent CMV infection, are really, those factors are really relevant for late post-engraftment infection, and especially with high mortality. Yes?
Is it not the other way around, that the infection is causing the GVHD?
Yes, but so you know that GVHD is the risk factor for infection, rather. So, but of course, in some situation we can observe that a bacterial infection, but only some type, and it was proved for acute, rather not for chronic graft versus host disease, may be related to this factor. So it is true, for instance, for Clostridium difficile infection. Okay, but it is generally more documented in acute, not in chronic graft versus host disease. But it is, of course, but we cannot exclude it. Let's go to fungal infection. So this is a picture which I like to present, because it shows all problems related to invasive fungal disease generally in patients after stem cell transplantation. First, we cannot diagnose all cases during patient's life, and so for now we can diagnose about 50% of cases. This diagnosis is really very, very difficult. Two main population, acute myeloid leukemia, and of course patients undergoing allogeneic stem cell transplantation. For autologous, it is not so great problem. And this is not very great problem now also to observe invasive fungal disease in patients during neutropenia undergoing stem cell transplantation. It is rather a phase when the patient is discharged from hospital but develops immunologic complication requiring steroid therapy. It can be graft versus host disease in most of cases, but not only, also other situation when steroids are given also increase the risk of invasive fungal disease. We have, first of all, problem with aspergillosis. This is the main reason of invasive fungal disease. However, we do observe also increasing rate of infection caused by Candida infection, and what is maybe the worst information, other than Aspergillus mold infection, because those infections cause mortality in very high percentage. For now, we, of course, treatment and effects of successful treatment is observed in about 50% of patients and is much better than many years ago, than 20 years ago. However, I don't think it is success if 50% of our patients after transplant, without acute leukemia, for instance, dying because of fungal infection. So that's why we are trying to fight with this. Here we have data based on almost 16,000 patients done in US, autologous and allogeneic transplant. It was prospective analysis showing that this problem of invasive fungal disease is seen first of all in allotransplant setting and is caused first of all by Aspergillus and is seen especially during first several months after transplant. But of course we cannot forget about Candida because it is mortality rate is very high during this infection. It is also difficult to diagnose. Most of fungal infection are observed in patients transplanted from alternative donors, from unrelated or mismatched donors, also from haploidentical donors with tedepletion. However, if we look at currently more commonly used transplantation, haploidentical transplant with post-Cy, in this group of patients, the rate of fungal infection is really very low. And this is true because we do have in our center also a lot of patients undergoing such form of transplant, and they do not develop fungal infection. We were afraid of it because we thought that this immune defect will be stronger, however, not in this context. So looking at fungal infection, the rate is really lower than in other, in comparison to, for instance, much unrelated donor with ATG. Mortality is substantial. Of course, we have progress, we have new drugs, we have new methods. We can monitor patients after transplant to look at the risk of infection, fungal infection. So there is improvement. However, as I mentioned, it is about 50% of patients who are dying because of invasive fungal infection all the time. The best progress is observed in invasive aspergillosis. Worst situation is in Candida, and the worst in patients in whom we do diagnose infection caused by other than Aspergillus infection, for instance, mucormycosis. Diagnosis of fungal infection is very difficult. That's why we have different levels of diagnosis possible when we just like kind of guessing. So we have only host factors and clinical criteria. We have also probable invasive fungal infection when we have some basis to think that there is a fungal infection and we implement treatment, and of course proven fungal infection when we have to give treatment because disease is established. So for patients from risk group, and all patients with allogeneic transplant belongs to a high risk group, generally most of them, maybe not very young patients transplanted in very young patients in very good condition, transplanted from sibling donor in complete remission of acute myeloid leukemia. It may be, we can consider this as a lower risk patients. However, most of patients are treated as higher risk patients, and they are given prophylaxis, primary prophylaxis for those who had history of invasive fungal disease during previous treatment. We use secondary treatment. Empirical treatment corresponds to possible invasive fungal infection, preemptive to probable, and targeted to proven invasive fungal infection. And the most important data, invasive fungal disease in the history, condition of the patient at time of infection onset, first of all, neutropenia, graft versus host disease, and steroid use. Level of diagnosis, because if we have a patient on possible infection, the chance that there is invasive fungal disease is about 15 to 20%, and probably those patients will go quite well in the future, but during the treatment. But those patients with proven, this mortality rate is about 50%. And of course, etiology, different forms of mold infection and candida infection. It is extremely important because we have to know what is the main problem in this setting. Site of infection, of course, for a mold infection, generally lungs, but also a central nervous system, bloodstream infection for candida, and but also other localization are very important, just like skin or different organs. Prophylaxis, given prophylaxis is important, form of treatment, empirical, preemptive, or targeted, and of course the outcome. Viral infection. So we can describe viral infection in two ways, as latent infection and sporadic infection. Those sporadic infection are related to some isolation or vaccination procedure, but latent infection requires from us some strategies to diagnose, monitor, and treat patients. And I would like to focus on two of them, CMV infection and EBV infection, and also show you some our late observation in that field. Let's start from CMV infection, which is well known, but all the time it is one of the most common and one of the most significant complications after stem cell transplantation. This reactivation is seen in about 50, almost up to 50%. However, in some situations, is really higher, especially after cord blood transplants. And unfortunately, despite we have different strategies, we still observe progression to end organ disease with, for instance, CMV pneumonia in 10 to 30%, unfortunately with 90% of mortality. Additionally, CMV disease or some resistant forms of reactivation require hospitalization of patients or prolonged hospitalization, which is costly and also influence on the quality of life of the patients. So there are several direct effects of CMV, some indirect complication related to secondary bacterial fungal infection or graft versus host disease, because it was proven that CMV infection can induce or exacerbate graft versus host disease, and of course some complications related to drug giving to those patients, myelosuppression and renal failure. We have procedures, we have diagnostic procedure given offered or mandatory for all donors and recipients. We have some strategies of prevention of primary CMV infection and strategies to prevent CMV disease in those who are seropositive, and treatment strategies of CMV disease. It is extremely important to look at serology of the donor and the recipient, because this combination influence in a very important way to the risk of reactivation and the risk of development of CMV disease. This is the most important determinants of CMV complication after transplant. Of course, in those patients who are seronegative and are transplanted from seronegative donor, the risk of infection and CMV disease is very low, is about 0. However, we do observe much higher problem in those patients who are seropositive and transplanted from seronegative donor, because in those patients the risk of reactivation and CMV disease is really very high, and it influences also on survival. And it was proven by different scientists and in different time, many years ago and recently, that this combination of seropositivity or seronegativity of the donor and the recipient are really very important and influence the outcome of patients with CMV infection. It is also important that reactivation and CMV disease are related to form of treatment. So it is much higher in patients undergoing myeloablative conditioning, and those who are treated from transplanted from the donor, unrelated donor or mismatched donor. It seems that source of stem cells, it is not very important, but conditioning and graft versus host prophylaxis influence the risk of graft versus host disease. It is also very important now, coming back to late infection, because we have our strategies to observe patients after stem cell transplantation up to 100 days. Today, we do observe also late reactivation of CMV infection up in longer time after this time of 100 days. And the picture, clinical picture of such reactivation is a little bit different than during first 100 days, because during first 100 days, we have, first of all, CMV pneumonia, and we have also some symptoms from gut, just like diarrhea, and also secondary to this graft versus host disease. But in patients with reactivation after 100 days, we observed, first of all, gut infection with diarrhea, and they are really very difficult to diagnose because CMV positivity in the blood is only in 20 to 30% of patients. But we can expect such late reactivation of CMV in patients with multiple reactivation during first 100 days, those patients who are presented with acute graft versus host disease, those patients who are transplanted from matched unrelated donor and from mismatched donor, and those patients who were CMV positive and transplanted from CMV negative donor. What about haploidentical transplants with post-SCI? We observe high rate of generally viral infection and especially CMV infection. It is a little bit higher than in patients transplanted from sibling or from matched unrelated, mismatched or matched unrelated donor. It is more than 50%. However, most of those patients are treated with first-line treatment. They do not require effort. So this is not more complicated cases than in other forms of treatment. However, this percentage is much higher if we look at CMV. It is also much higher if we look at other viral infection. I would like not focus on it. However, BKV virus is very prominent in this population of patients. It is also very interesting to look at viral load and the risk of CMV disease in patients who are during or undergoing our strategy. It occurred that viral load is really very important and is associated with higher risk of CMV disease. Of course, we can diminish this risk with use of preemptive therapy, which is standard procedure. However, it still exists, the risk still exists, and this increased viral load is also related to not only CMV disease, but also secondary bacterial and fungal infection, increased risk of death not caused by relapse, but is not related to graft versus host disease. This is the standard procedure, our standard management of patients with CMV infection. Prophylaxis for now is not used in many centers, only some selected centers, first of all, using cord blood transplants, but in most of centers we use preemptive therapy based on monitoring of CMV in peripheral blood. However, it may be changed in the future because several months ago, letermovir for prophylaxis was labeled. So, and that's why I think that was registered, and I think that soon we can use this drug safely for our patients, and that's why prophylaxis will be more, maybe more common than for now. And of course, therapy almost with the same drugs used for prophylaxis, preemptive therapy, and for the treatment. And now I would like to go to EBV infection. So this is very specific virus. I do interested in from my scientific point very much, because it is very specific virus which can cause B-cell proliferation and lead to form of secondary neoplasm in patients after stem cell transplantation. This is post-transplant lymphoproliferative disease. This is also one of the viruses, just like CMV, which is very common in adult population. So more than 80% of adults are EBV seropositive generally. So that's why it is very difficult to avoid seropositive donor and seropositive recipient. We have different definition described described by ESIL conference of EBV infection, and the most important is the last point, which is post-transplant lymphoproliferative disorder, which is neoplastic complication after stem cell transplantation. This is not common, it is rare, but life-threatening complication, especially when diagnosis is established is delayed. We have strategy to monitor, to assess serology before transplant of the patient and of the recipient, and to monitor with PCR EBV after transplant, but it concerns only patients undergoing allogeneic stem cell transplantation. We have also a strategy to treat those patients with anemia and those who are presented with clinical symptoms. So we call this treatment preemptive or targeted. It is extremely important because development of post-transplant lymphoproliferative disease is increasing. It is probably the result of change policy in transplantation generally. It develops usually during first year, usually during first 3, 4, 6 months. And mortality is really very high in those patients who develop PTLD. Today we know that with use of preemptive therapy with rituximab, for instance, we can improve this survival, and most of patients really survive, about 60% can survive. However, it requires early recognition of such situation and to start with this preemptive therapy very early. So we decided in our infection diseases group to look also at influence of EBV status of the donor and recipient on transplant outcome, how, just like it was proven for CMV serostatus. So we looked at overall survival and relapse incidence, non-relapse mortality, and we did not find any influence. However, we proved that transplant from any seropositive donor influence the risk of a little bit acute graft versus host disease, but in very important way, chronic graft versus host disease. It was proven for a very huge population of patients of acute myeloid and acute lymphoid leukemia, but currently we looked at, again, huge number of many thousands of patients with other malignancies, if it is truth also for this group of patients, and it is. So we are trying to prepare a manuscript now. So I think that it is also very important, just like CMV and also EBV, serostatus of the donor and recipient before transplant can influence the transplant outcome, and this is really very important. And I must say that we could analyze it based on data thanks to you, yes, because we could analyze thousands of patients with data which were provided by you, and that's why it is so important. So the most important data looking at viral infection, serology of the donor and of recipient before transplant for CMV and for EBV for sure. Time to reactivation is very important, early versus late. Viral load for both infection, CMV and EBV. Site of infection in CMV infection, lungs, GI tract, other localization. Clinical characteristic of PTLD, it is clinical characteristic of lymphoma, and prophylaxis treatment on different level, and of course the outcome. And in the end, I would like to show you some our proposition to prepare MedB for the next for new registry. So the Professor Ljungman proposed that in the SCORE module it will be only CMV. And probably it will be. However, we would like to have module which will be constant, and additionally some modules for, of course, for research. This is one of the part of this constant module, because we would like to have serology of the recipient and of the donor in detail. So this is the first part related to recipient. This one is related to the donor. We would like to have detailed information about etiology and localization characteristic of infection of all patients in different time point after transplant. And we prepared also a list of pathogen to be used because it is a little bit easier. It is not ready. This is, of course, we are working on it all the time, and so we improving it. So this is this part which we dream about it that it is constant part of this new registry. And with this, I would like to thank and stop. But what is very important, with improvement of treating infection, we can improve outcome of transplant, and this is our goal. Thank you very much.